All right, good afternoon, everyone. Thank you for being here. I apologize for being a minute late. I'm still trying to get a little settled here. But we are going to go ahead and get started. Welcome to the penultimate, I think that's the right use of the word, budget hearing for this subcommittee. Tomorrow will be the final budgets that we will hear. Today we are hearing our single largest section of the budget, which is the medical care systems. That's the medical care programs, which is the Medicaid budget. We will begin today with the analysis from Ann Wagner and then move on to the department. We do have a fair number of people signed up to testify orally. That's going to be about 11 people. So we are going to limit testimony to 2 minutes per person. Please stick to that time. And from the public, obviously, the department will have all the time they need, and so will the analyst. Ann, please kick it off.
Thank you very much, Mr. Chairman, members of the committee. As you said, today I'm presenting the analysis for the Medical Care Programs Administration under the Department of Health, and this administration manages the Medicaid and the Maryland Children's Health Programs, or MCHIP. The fiscal 24 allowance provides $12.5 billion, which is a $447 million decrease from fiscal 23. On this first page, I just want to highlight that Medicaid and MCHIP are jointly funded with state and federal funds, and Maryland receives at least a 50% federal match on qualifying Medicaid spending, with certain eligibility populations receiving enhanced matches. So children under the MCHIP program receive 65% federal matching funds, and childless adults under Medicaid after the ACA expansion receive 90% federal fund matching funds. And so this leads to the Medicaid budget being predominantly supported with federal funds each year, and you'll see that that fund split does fluctuate slightly year to year. And Maryland also received an enhanced federal match during the COVID-19 public health emergency. So that is contributing to the shift in the fiscal 24 fund split so that more general funds are needed compared to the prior years shown on this page. So I'm going to jump to the program description beginning on page 4. Medicaid provides comprehensive health benefits to eligible individuals who meet certain income thresholds or are considered medically needy. The Maryland Children's Health Program also provides health coverage, and it extends eligibility to children with higher family incomes than the normal cutoff for Medicaid. Exhibit 1 on page 5 shows broad categories of Medicaid enrollees, and it compares each group's share of enrollment compared to the share of spending, with fiscal 22 shown as an example year. And so this exhibit shows that some smaller eligibility groups largely drive program costs, as they make up a much larger share of spending compared to their share of total enrollment. And so you can see this is true for disabled adults and children, as this group accounts for just under 8% of total enrollment, but then 22% of fiscal 22 costs. And so these populations require higher cost services, higher healthcare utilization overall. And on the opposite side, you're seeing the group referred to as other children enrolled in Medicaid and MCHIP are the opposite, since they make up 41% of enrollment, but then only make up about 18% of total program costs. The other background information I'll briefly highlight is on the next exhibit, Exhibit 2. Most Medicaid enrollees are served under the managed care program referred to as Health Choice. Exhibit 2 shows that 87% of enrollees as of November were served in Health Choice, and under this program, each individual is enrolled in one of 9 managed care organizations, or MCOs. MCOs are paid a capitated rate to provide Medicaid coverage or covered health benefits to their members. And then other individuals not in the managed care program are mostly Medicaid enrollees in long-term care facilities and individuals who are dually eligible for Medicaid and Medicare. And this group receives coverage on a fee-for-service basis. So I'll now turn to the performance analysis section beginning on page 8. And that starts off with MDH's monitoring of MCO performance. That page lists a few different ways that MDH tracks MCO quality, but this analysis will focus on HEDIS measures and the value-based purchasing program. And so first, looking at HEDIS measures, these are a performance monitoring tool used by health plans nationally, and they look at a wide variety of quality domains and components. Exhibit 3 shows how Maryland MCOs performed in the latest 3 calendar years, shown as the percent of HEDIS measures that were equal to or above the national mean. In calendar 21, the MCO average was just over 50% of HEDIS measures being equal to or above the national mean. And so we also note there's been a pretty sharp decline in performance on these measures since calendar 2019 across almost all of the MCOs. And so even though this timing overlaps with the COVID-19 public health emergency, we would also expect other health plans nationally to be impacted by the pandemic, since this is comparing Maryland MCO performance to the national mean. And so MDH is asked to explain why Maryland MCOs reported worse HEDIS outcomes in calendar 20 and 21, and then if there are any particular reasons that the MCOs would have been disproportionately impacted by the pandemic compared to other health plans nationally. So I'll skip ahead to the next item under performance analysis that begins at the bottom of page 11, and that discusses the value-based purchasing program. Under this program, MCOs receive certain incentives and are charged disincentives up to 1% of their capitated rate. This depends on their results on certain healthcare quality measures chosen by the department, and the 7 measures used in calendar 21 are listed on page 13. Originally, this program was designed to be budget neutral because the charged penalties would fund the earned incentives. That first round of incentives was referred to as the primary distribution, but if there were more penalties collected than was needed for the incentives, then a secondary distribution of bonuses would be provided to the top 4 performing MCOs. This program could no longer operate exactly that way because of a federal requirement that MCO rates must be actuarially sound. And so because Maryland's rates were set at the very bottom of that range to be actuarially sound, charging disincentives or penalties would have brought certain MCOs below that level. And so this led MDH to implement the program with incentives only in calendar 2018. And then in calendar 2020, MDH only charged penalties to an amount of 0.5% of capitated payments to maintain that actuarially sound level. And then I will show Exhibit 5 on page 14 shows the VBP report results in calendar 21. There you're seeing that most MCOs did fall in the disincentive range. However, the MCO rates were again set at the bottom of the required range. And so MDH is not charging penalties and is covering the $2.7 million in earned incentives with funds in the fiscal 23 working appropriation. And so if the program was operating as it was initially established, there would be about $28 million more in penalties than incentives that would have been distributed through a secondary distribution. And so the BRFA of 2020 changed the way the secondary distribution was to be paid out beginning with calendar 21. And the new methodology is described on the next page, so on page 15. However, the calendar 21 value-based purchasing report only published the primary incentive payments and did not provide any calculations for a secondary distribution. And so this is despite the working appropriation, including funds to cover VBP costs. And based on calendar 21 results, that amount would have been at least $4.5 million more than needed if a secondary distribution was paid out. And so the department is asked to clarify whether it is implementing the secondary distribution for calendar 21 and to discuss how it is planning to spend any remaining funds budgeted for the value-based purchasing program in fiscal 23 if a secondary distribution is not being administered. Considering the issues with charging disincentives, MDH has transitioned to a new incentive-only program. That's referred to in regulations as the Population Health Incentive Program, and that will be implemented for calendar 22 results. And the fiscal 24 allowance includes $36 million to fund the first year of that program. I'll move on to the budget discussion, beginning with fiscal 23. Looking at page 17, this includes a discussion of the 4 proposed deficiency appropriations across Medicaid and MCHIP, and that would add a net total of $720 million in total funds, mainly due to increased enrollment assumptions. I'll discuss those later on. But I do want to highlight one special fund adjustment made in one of those deficiencies related to MCHIP premiums. As part of that program, children with family incomes above 212% of the federal poverty level normally pay monthly premiums, but these payments were suspended during the COVID-19 public health emergency by state-level emergency order. And so MDH is asked to comment on when it plans to resume collecting these monthly premiums. 2 proposed deficiencies account for the continued 6.2% enhanced federal match on Medicaid spending and then a 4.34% enhanced match on MCHIP spending that was initially tied to the national COVID-19 public health emergency. Exhibit 6 shows the federal funds that Maryland received under Medicaid, totaling between $400 and $500 million per year from fiscal 21 through 23. The enhanced match is set to phase out beginning April 1st until it fully expires at the end of this calendar year. So that's causing the decline in federal assistance between 23 and 24. As a result of the enhanced match ending, more general funds would be needed in the allowance to backfill this support. And so while total Medicaid spending decreases in the allowance, there is an increase in general fund spending by over $500 million, mainly to backfill these federal funds. At the top of page 19, the analysis discusses two items that were added by budget amendment in fiscal 23 and are supported with federal funds from the American Rescue Plan. This includes $50 million provided to Medicare Advantage plans to help stabilize that market, specifically the plans operating in Maryland, and $25 million to support skilled nursing facilities, mainly for staffing costs related to the COVID-19 pandemic. And so MDH is asked to provide an update on how the American Rescue Plan funds were distributed and when they will be spent in fiscal 23. The final fiscal 23 item relates to the MCO risk corridor. This is a risk-sharing agreement that MDH and the MCOs entered into midway through calendar 20, and this allows for the state and federal government to share in savings or losses when healthcare utilization was very uncertain due to the pandemic. MCOs annually spend a percentage of their capitated payments on eligible medical expenses. That's referred to as the medical loss ratio, or MLR. And MDH requires MCOs to report an MLR of at least 85%, or the department could recover some of that difference. And under the two-sided calendar 20 risk corridor, MDH and the federal government agreed to split losses with MCOs if they spent above certain MLR thresholds, or would split savings if MCOs spent below certain thresholds. And so Exhibit 7 shows the MLR ranges that resulted in savings, showing that 5 of the 9 MCOs fell in these corridors. And so this led to $106 million in total recoveries between the federal and state government, with MDH's share being $35 million. And so the department is asked to provide an update on the timing and method for that $35 million in recoveries to be accounted for in the state budget. Moving on to the discussion on the allowance, Exhibit 9, I'll skip ahead to pages 23 through 25. Exhibit 9 outlined the changes between the fiscal 23 working appropriation and the fiscal 24 allowance, and that sums to a net reduction of $447 million. I'm going to skip to the budget discussion, starting with Exhibit 10 on page 26. So this exhibit shows special funds budgeted under the Medicaid and MCHIP programs in fiscal 23 and 24. This reflects that the allowance decreases by about $77 million in special funds. This is mainly driven by a $50 million reduction in the Medicaid deficit assessment. This is imposed on hospitals in Maryland, and that $50 million in special funds would be backfilled with $50 million in general funds. And both of those actions are contingent on this year's BRFA, or Budget Reconciliation and Financing Act. As was discussed at the budget hearing for the Health Regulatory Commissions, this is just one of the actions that the HSCRC is taking to increase Medicare savings and to try to help the state meet the total cost of care targets. HSCRC also received federal approval to increase the public payer differential in fiscal 24. And so this differential allows Medicare and Medicaid to pay slightly lower hospital rates than other payers. And so this is estimated to provide $26 million in Medicare savings, but it would also provide $16 million in savings to Medicaid for hospital costs that have not yet been reflected in the allowance. The remaining special fund decrease is attributed to the Cigarette Restitution Fund. As you can see, support for Medicaid from this fund falls by $29 million. With just $46 million budgeted in the allowance for Medicaid, the CRF is estimated to close fiscal 24 with a balance of over $19 million. And so considering this large closing balance compared to prior years, DLS is recommending reducing $15 million in general funds from Medicaid and authorizing a budget amendment to replace those funds with an equivalent amount of cigarette restitution special funds. So next, the analysis discusses Medicaid provider rate increases. Exhibit 11 outlines the funding for rate increases in the Medicaid allowance, with nursing homes and MCOs driving the overall $215 million increase. Nursing homes receive the 4% rate increase as required in chapters 10 and 11 of 2019, or the Fight for 15 legislation. Home and community-based providers also receive the mandated 4% rate increase in the allowance, but this funding is offset by the end of a one-time additional 4% rate increase supported with American Rescue Plan funding that was provided specifically for home and community-based service providers. And that additional 4% rate increase is scheduled to end at the end of fiscal 23. And so that's why that's offsetting the fiscal 24 mandated 4%. And so I will note this exhibit excludes funding under the MDH Office of the Secretary that accelerates the mandated provider rate increases that is contingent on the enactment of legislation accelerating the $15 minimum wage. That funding was discussed in the MDH administration analysis, but I'll note that the increase for Medicaid providers receiving the mandated rate increases would be accelerated to 12% in fiscal 24 when those funds are included. In fiscal 23 and 24, home and community-based service providers continue to receive additional rate increases that are funded with American Rescue Plan funds. And so that issue was discussed more at length in the MDH overview, but I did want to note that Exhibit 12 shows the HCBS provider rate increases specifically under Medicaid, including the 5.2% rate increase that becomes ongoing spending in the allowance as the allowance backfills that American Rescue Plan support with state funding after the federal funds must be fully expended by April 1st, 2024. So then the analysis moves to a discussion of Medicaid and MCHIP enrollment trends, starting out with Exhibit 13. This shows the substantial growth in Medicaid enrollment from fiscal 19 through the current fiscal year. And this is mainly due to the requirement that state Medicaid programs freeze disenrollment as a condition of receiving that enhanced federal match during the COVID-19 public health emergency. And so over this time period shown, there is a 25% growth in the average enrollment per month. And on the next exhibit, I'll focus mainly on the third bar that's labeled COVID-19 public PHE growth. This shows that the added enrollees between February 2020 and January 2023, it shows the added enrollees by their eligibility categories. And so while the group of ACA expansion makes up between 20 and around 25% of monthly enrollment, this group made up of about 40% of the new enrollment added during the pandemic. And so I'll note here that the Medicaid enrollment mix can have a large impact on general fund need for the Medicaid program. And that's because certain eligibility groups receive enhanced federal matching funds. So that ACA expansion group does receive a 90% federal match. And so the increased enrollment for this group would greatly increase total fund cost under Medicaid, but has less of a general fund impact versus groups like parents and caretakers that typically receive a 50% match. And those groups that receive 50% matches receive 56.2% matches during the PHE. Moving forward, the Consolidated Appropriations Act passed in December decoupled the end of the decoupled the end of the freeze on disenrollment from the end of the COVID-19 public health emergency, and instead allowed states to begin a 14-month redetermination process beginning on April 1st, 2023. The planned redetermination process in Maryland is described on page 32, but overall, MDH plans on using the maximum 14 months allowed to work through that first round of redeterminations. MDH has been conducting eligibility renewals throughout the pandemic, but the first renewals that could end in disenrollment will start up again April 1st, with Medicaid coverage being terminated for the first group starting June 1st. Most Medicaid enrollees will go through the process in the month that they first enrolled in Medicaid or MCHIP, but there is a group of about 186,000 individuals that MDH identified as likely being ineligible, and that could be due to the individual reporting an income that's too high to be eligible for Medicaid, or individuals aging out, becoming eligible for Medicare, among a couple other reasons that this group is likely ineligible. In last year's budget bill, MDH is prioritizing these individuals for the renewal process in the first 6 months. And I'll note that this number of 186,000 individuals is significantly higher than prior estimates when the department reported approximately 55,000 individuals who would likely be ineligible. In last year's budget bill, Medicaid funding was restricted pending the submission of quarterly reports on the redetermination process and the status of the public health emergency back when it was still expected to end before fiscal 23. And so the department has submitted one of its quarterly reports on January 9th, and in this analysis, DLS is recommending the release of $250,000 of the restricted funds unless there are any concerns raised by the subcommittee. Considering the freeze on disenrollment that ending on April 1st, 2023, DLS is again recommending budget language that restricts funds pending the receipt of quarterly reports on the redetermination process. Next, in Exhibit 15, the analysis discusses DLS's fiscal 23 and 24 enrollment forecast as it compares to the enrollment assumed in the budget plan. Both forecasts project significantly higher enrollment in fiscal 23 than was originally budgeted in the legislative appropriation. That's due to the COVID-19 public health emergency being extended multiple times, and therefore the freeze on disenrollment was pushed further and further back. There is a deficiency that adds about $685 million to Medicaid to cover this increased enrollment and to update the budget for utilization and rate changes. And so with this higher starting point in fiscal 23 enrollment, the fiscal 24 allowance is then based on much lower average monthly enrollment, as disenrollments are expected to start back up after April 1st. Due to the decline in enrollment from over 1.7 million in fiscal 23 to 1.56 million in fiscal 24, Medicaid spending in the allowance decreases by more than $900 million compared to fiscal 23. That reduced spending also accounts for utilization assumptions, but the largest factor in this is the enrollment assumptions, and so that's the largest factor leading to that overall decrease in Medicaid spending in the allowance compared to fiscal 23. And so while both the budgeted enrollment and DLS enrollment forecast show this large decrease from fiscal 23 to 24, the assumptions on enrollment mix by eligibility group between the two models lead to different estimates of total Medicaid spending and general fund need. Exhibit 16 shows recent actual enrollment trends among children and parents enrolled in Medicaid, showing the gradual increase while disenrollment had been frozen. The dotted lines show that for children, the budget and DLS both assume that fiscal 24 enrollment will decrease as disenrollments start back up. However, looking at the trend for parents, the budget assumes that the parents and caretakers group will remain at the elevated level, while the DLS forecast projects that this group will see a similar trend to children and would decrease once disenrollment begins. And so turning to Exhibit 7, this takes the per person cost in the allowance and estimates the total cost impact of having different enrollment by category in the two models. The 47,000 person difference in parents and caretakers would lead to about $290 million in reduced total fund costs and spending, and has a significant general fund impact of over $100 million in less expected general fund spending due to parents and caretakers having a 50% federal fund match typically. And even though DLS ends up slightly higher in enrollment for some groups like children in Medicaid and the ACA expansion group, this large difference in projected parents and caretaker enrollment drives an estimated net cost difference, with the DLS forecast projecting about $100 million less in general fund spending than is included in the allowance. And so to sum up this enrollment discussion, DLS found that the fiscal 23 working appropriation as adjusted by deficiencies is adequate to cover projected costs. But the fiscal 24 allowance is overfunded based on the anticipated enrollment mix in the DLS model. And so I had also mentioned earlier that there was an estimated $16 million in savings that Medicaid would receive from the HSCRC cost saving actions and the increase in the public payer differential. And so combined with those with enrollment projections, DLS is recommending a reduction of $115 million in total funds from the Medicaid budget in fiscal 24, with $70 million of that being in general funds. So I'll now move over to personnel data, and that is shown on pages 37 and 38. Medicaid receives 11 contractual conversions in the fiscal 24 allowance, but at the same time, there is a net increase of 56 contractual FTE, or full-time equivalents. Many of the new contractual positions have similar roles as the 11 contractual conversions, and so these positions are being added as Medicaid is also reporting over 80 vacancies as of December 2022, with almost 25 of these positions being vacant for more than 1 year. So MDH is asked to explain why the net increase of 56 contractual positions is best served with contractual personnel rather than as new regular positions, or repurposed long-term vacant regular positions for these staffing needs. And then moving to the issue section very briefly, that begins on page 39. This first item relates to an audit that OLA annually conducts on closeout transactions. The fiscal 24 closeout audit found that the department had an automated tracking system for federal fund revenue accruals, and when 16 entries were sampled by OLA, the department could not support the propriety of $3.5 billion in federal fund accruals. The audit specified that the department's automated tracking process did not collect enough information to be certain that federal fund accruals could be recovered in the next year. And so MDH is asked to discuss how it is resolving this significant audit finding, including how it is changing internal accrual tracking and when these changes will occur. The second issue outlines various changes made to the Medicaid program recently that generally expand healthcare coverage. I'll highlight that legislation from last year required Medicaid to begin covering certain dental services for adults beginning January 1st of 2023. Previously, only children and certain adult groups qualified for Medicaid dental coverage, and so the department is asked to provide an update on implementation of this coverage expansion. The other item to note is third on this list relates to the relating to the Community Options Waiver Program. I discussed these changes in the health overview more at length, but just want to highlight here that DLS is recommending narrative requesting 2 reports on the Community Options Waiver and Community First Choice Program financial and registry data. And so finally, the recommended actions are found beginning on page 42. I'll skip the recommendations that I've already described. So looking at items 2, 7, and 8, these are all language or narrative requesting reports that were requested in last year's budget bill or joint chairman's report, but still haven't been submitted. So we include them here for your consideration. And then items 3 and 9 are restrictive language recommended annually that prevents funds from for Medicaid provider reimbursements and the Maryland Children's Health Program to be transferred out, or prevents the funding from being transferred out of those respective programs. With that, I think I covered all the recommended actions, so I'll conclude my presentation there. Thank you.
Thank you, Ann, for your comprehensive analysis. Any questions for the analyst? Delegate Chetty.
Thank you, Mr. Chair, and thank you so much for the great analysis as always. So as you were going through the report, I flagged a couple areas that I just had a couple of clarifying questions. So on page 24 of your report, where you note at the top that provider rate increases, I'm just curious if you know, or if this question might be more appropriate for the department, how close that brings the rate reimbursement to parity to Medicare reimbursement.
For the physicians evaluation and management group specifically, I don't think we highlighted that particularly because I believe the allowance actually level funds those. So to the extent that Medicare rates, and I'm sorry, I should say fiscal 23, those rates were budgeted at 100% of Medicare rates. And so to the extent Medicare rates increase next year, those rates are level funded, so they would fall slightly below 100%. So yeah.
Okay, so they're in parity now, but they could be not in parity going forward in the event that Medicare increases provider rates?
Yes, I believe so. And I'll, sorry, is that
okay?
Right?
No, this
I can allow the department to correct me. I'm happy to allow that.
Yeah,
I mean, to ask for that.
Okay, that's good to know.
Yes.
That's good to know. And then also curious if you can share, please, at the bottom of page 24, there is a negative 2,500 for maternal and child health population health improvement fund. Can you elaborate on that a little?
Yes, so that funding is special funds coming from the HSCRC. I discussed the regional catalyst program, and that there was an action in the BRFA recently from a prior year that created a special fund so that the HSCRC could take funding from that regional catalyst program and basically provide it to Prevention and Health Promotion or Administration, or FIPA, and then Medicaid as well. And so that funding is about $10 million each year over, I think, the next 4 years. I would have to double check the other analysis. But I believe the reason this is decreasing is that there was some of that funding accounted for under HSCRC. So I think I would have to dig a little deeper into the exact accounting of those funds because HSCRC did have some of those special funds budgeted there too. And so I can get back to you on clarifying how those funds are budgeted.
Okay, thank you. I appreciate that. That's it for me now. Thank you.
Thank you. Any other questions? Seeing none, let's bring up the department, Secretary Scott, and your team. I had a little moment when I looked at the agenda and saw that Medical Director Stephen Chu was listed on here. Thought I went back in time a little bit. So, but let's go ahead and begin and hear the department's response.
Good afternoon, Chairman Resnick, Vice Chair Chang, and members of the subcommittee. Laura Herrera-Scott, Secretary of Health, and with me is Tricia Roddy, Acting Medicaid Director, and our Chief Financial Officer, Emily Brandenburg. Also available for questions are Jennifer McElvaney, who's the Finance Director for the Medical Care Programs, and Webster Yee, Assistant Secretary of Health Policy. I do want to add Webster will be leaving the department and joining DHS, working with Secretary Lopez as his next Chief of Staff. So I wanted to personally say thank you for all the work he did at the department and certainly supporting me in the last 6 weeks of my onboarding. I also want to thank Ms. Wagner, as always, for your insightful analysis. But before I turn it over to Tricia, I just wanted to highlight a few items for the committee. Over the next several months, one of the top priorities is to successfully unwind policies related to federal COVID-19 public health emergency, and that includes everything from the tents that we have to Medicaid. And as part of that unwinding, a key policy that is coming to an end that has allowed for continuous Medicaid eligibility is as of April 1st, will start to end. And so the enrollment that we've seen in Medicaid that has steadily risen during the public health emergency, consistent with the national trends, will now start to see the other go in the other direction. We will resume redeterminations in April, and we expect some individuals to lose Medicaid coverage. Changes in eligibility status may occur due to changes in income or household circumstances. It is imperative that Marylanders who are no longer eligible for Medicaid have the opportunity to access affordable, high-quality health care, including coverage through the Health Benefit Exchange. We are partnering with the managed care organizations, the Health Benefit Exchange, the Department of Human Services, CRIS, which is the state HIE, and other users with a combination of target outreach and paid media campaigns to reach every affected individual. Unlike other states, Maryland never stopped its eligibility checks during COVID. However, we take seriously our responsibility to make sure that all of our Medicaid beneficiaries have every opportunity to maintain their access to health care coverage. The second priority, which our CFO, Ms. Brandenburg, will discuss further in our response, is the recent Office of Legislative Audits FY22 closeout report. The department agrees corrective actions are necessary to strengthen the accounting practices and documentation at MDH, and then while the corrective action will take some time to complete, the current administration, including leadership of both MDH and DBM, are committed to prioritizing this effort. I wanted to extend a special thanks to DBM Secretary Grady and her team, as well as Greg Hook, legislative audit staff, for their help over the past few weeks on this issue. And with that, I'll turn it over to Tricia Roddy.
Thanks, Secretary Herrera. Scott, and I will be doing this presentation with Amelia Brandenburg. I'll do the first part, and then I'll turn it over to Amelia. First of all, we were asked to comment on our HEDIS scores of our MCOs and how it compared nationally. I think generally we all know there was an underutilization that occurred during the pandemic. I think generally other states, we weren't impacted all the same across the country. Some of the issues that we know contributed to that underutilization were threefold. One, healthy people were just not accessing services like they were previously. There were staffing shortages, and we still hear those staffing shortages amongst our providers in Maryland. Office closures were happening and consolidations of service practices were occurring. Also, just to note how HEDIS collects its measures, some of the measures are collected almost entirely from claims data. Other measures require you to actually go into an office and pull out the medical charts. So obviously, most medical offices did not want personnel coming in for a HEDIS collection while the COVID pandemic was happening. So many of them prevented individuals from coming in and reviewing those charts. So that contributed to the lower reporting of our MCOs. You know, I will note that we did offer audio-only services during the pandemic, and we're continuing those going forward. We had the providers who most used that service, of course, was the behavioral health providers, but generally it still did not make sure that utilization was at normal levels before the pandemic. Secondly, we were asked to comment on our value-based purchasing program, specifically for calendar year 2021, and sort of in the payouts and collection of disincentives. I know, Chair Resnick, we've had this conversation many times going back to 2020. So I think in order to paint the picture of really what was happening with our value-based purchasing program, it's important to go back to calendar year 2020. So we had established our contracts with our managed care organizations. We signed those well before January of the calendar year, and of course the pandemic hit in March. So we were contractually obligated to administer our value-based purchasing program according to the contract terms. So what this meant is that we had to collect disincentives. It didn't matter about the performance of the MCOs. We still had to collect them according to the contractual terms. As Ann pointed out, the way the value-based purchasing program operated at that time was that we were to keep $0 from those collections. We were supposed to distribute it across the MCOs and based on whether or not they had incentives, and if they didn't have incentives, we still had to pay it out to the 4 highest MCOs. So what that meant is that certain MCOs got incentives when they had a net disincentive overall. It also meant that because we were collecting, because of the underutilization, we were collecting a pretty high disincentive amount. And at the same time, remember, enrollment is growing because we're not disenrolling anyone. So the collection, it's a percent of capitation rate. So as enrollment grows, of course, we're collecting more money and distributing more money to the 4 highest MCOs. So what it resulted in was certain MCOs getting excessive payments, some around 3 to 4%. Normally, they're capped at, they're around a 1% of a MCO's capitation payment. So we wanted to make sure that that didn't occur for calendar year 2021. And so we made sure that in the contract, it stated that if the actuaries could not certify and collect disincentives, that the rates couldn't allow for the collection of disincentives, we would not be doing it. And in fact, as Ann said, it was the actuaries certified it at the bottom of the rate range. That meant that we could not collect disincentives. The MCOs were notified at that time that we would not be collecting disincentives. And so what was provided in the contract is that we could provide incentives based on what was collected in what's called a Health Choice Performance Fund. And what was available in that fund for calendar year 2021 was we were able to pay 90% to the MCOs who received round 1 incentives, and those were 2 MCOs. It was Jai and Kaiser. And so that is what is being paid out. And again, as Ann mentioned, going forward, we have a new program called the Population Health Improvement Program, which again doesn't rely on disincentives in order to fund the program. It's built on top of the capitation rates. It's 0.5% of the capitation rate. And so therefore, we won't have this issue going forward about whether we collected disincentives to fund it or not. Next, we were asked to comment on our plans to collect monthly MCHIP payments. These premiums will start May 1st of 2024. And again, the reason why we picked that date was because there is a maintenance of effort requirement with the federal public health unwinding initiative. So essentially, you cannot charge premiums to individuals prior to their redetermination. So we needed to align when we think we're going to be all completed with redeterminations in order to start those collections again. So that's why we picked May 1st, 2024. Next, we were asked to update the committee on the ARPA funds that went to Medicare Advantage plans as well as skilled nursing facilities. We've laid out the schedule of payments for the Medicare Advantage plans. It was $50 million in total. The first payment went out when they signed the contract. There are 3 additional payments. The second one has gone out, which was February 28th. The next one is May 31st. And then the following one will be August 31st. There are some requirements with those before those payments are sent out. We have to ensure that those plans spend a certain proportion on medical services and that these funds don't just go directly to profit. And then also the nursing home payments, the amount of the payment is based on the total Medicaid reimbursement, the proportion of it, and it is going out essentially for most providers in 2 payments. Their first payment is 70% of the award, and then they'll receive the remaining 25%. Those funds, the first 75%, has all been released, and they should receive them within the next few weeks. Next, we were asked to comment about the 2020 risk corridor recoveries and how they were budgeted. And it was simply a matter of timing. When we put together the budget, it was in 2021, and we didn't try to estimate what those recoveries might be from the risk corridor. It was, again, we have never done a risk corridor like this, and we've never had a pandemic, so we were truly not, we didn't really have a good estimate of what would be coming back to us at the end. We will be building this quarterly projections in a potential reversion at the end of the year. Next, we were asked about reducing the $15 million in general funds in place of CRF funds, and we respectfully disagree and support the governor's budget. Next, it talks about the reports and withholding the pandemic enrollment reports around the unwinding and withholding funds until we submit those reports. We have no problem submitting the reports, but we respectfully disagree about withholding funds. Please note the federal government is going to be requiring monthly reports from us on the unwinding and also our enhanced federal match that we're going to be getting until the end of the year. It starts to decline between now and down in December. And in order to get those funds, we have to submit our reports. So we will be providing them to CMS and others, and of course, you will get those reports as well. Next, we were asked to comment on DLS's recommendation to reduce our budget by $115 million because of different enrollment estimates. Again, we respectfully disagree. We would like to sit down with DLS and work through those numbers. From what we can tell in terms of what DLS is cutting in terms of enrollment, it looks as though DLS is cutting about 242,000 individuals compared to current enrollment. And as Ann said, because we've been doing redeterminations throughout the pandemic, we've been able to identify individuals who most likely aren't eligible. So those are people who basically have turned 65 and now moved from from the modified adjusted gross income calculation into our age, blind, and disabled population. And now they will have an asset test attributed to them. And so those individuals most likely will not be eligible under those circumstances, as well as we can identify changes in income. In addition, our budget didn't account for the federal requirement to implement continuous eligibility, 12-month continuous eligibility for children. The federal government now is requiring states to implement this by January 1st of 2024. Maryland is going to be implementing it earlier. We're targeting for August because we want to take advantage of it while we're doing this massive redetermination effort. So again, while children will be obviously losing coverage through the unwinding, we will also be increasing our children enrollment because of the 12-month continuous eligibility initiative. And so once you reduce the children from the 187,000, we're about 132,000. And so again, because of the vast difference in enrollment estimates, we'd like to sit down and work those through with Ann. Next, we're asked to comment about our contractual staff versus permanent PINs. And what I can say is the administration, this is one of their top priorities, and working with all of us in terms of developing a comprehensive, robust staffing plan. So we're very grateful for the permanent positions that we did get in the budget as we work out this more comprehensive plan. And we do have some outlined in our response where some of the special payment payroll positions are going. Most of them they're not temporary, it's not temporary work, except for the IT functions. But we're happy, again, to share that more comprehensive plan when we have it developed. So with that, I'm going to turn it over.
Thank you, Tricia. We were asked to discuss the steps we were taking to resolve our significant audit finding and explain how we are changing internal accrual tracking processes. And I want to reiterate with the Secretary's comments. We agree corrective actions are necessary to strengthen our accounting practices and documentation at MDH. And while corrective action is going to take some time to complete, the current administration, including both the leadership of DBM and MDH, are committed to prioritizing this effort. We're working closely with DBM and the legislative auditors to address the closeout audit findings. A formal action plan has been developed that includes the creation of a joint correction action team, the implementation of control procedures, processing corrective accounting transactions, and identifying any additional resources that may be needed. We have a scheduled joint MDH-DBM corrective action team meeting scheduled for next Wednesday, and at this meeting we're going to discuss the status of our closeout items and our test items and the documentation we've been able to collect. We've been advised that the auditors will provide formal updates to this legislature as corrective actions are taken, and we anticipate MDH will fully resolve the audit findings. Medicaid specifically has had a work group project in place for several months, examining and updating current procedures in place. The first step is to perfect the calculation and timing of adjusting entries to ensure the general versus Medicaid federal versus CHIP federal fund splits are reflected in FEMAS based on the actual quarterly federal claims. Then federal revenues can be matched against the federal expenditures on a quarterly basis, and our goal is to have this portion of the work completed before our fiscal year 23 closeout. We were asked to provide an update on the implementation of the adult dental coverage expansion, including any plans to change the financing structure for dental services. We have additional information in our written response, but we implemented coverage for adult dental services on January 1st of 2023. And as of February 24th, there was just over 27,000 unique participants and 716 unique providers that have billed for just over $9.2 million. At this time, we are not pursuing a capitated payment model for delivery of dental services, but we do have an RFP out for the Maryland Medical Dental Benefits Administration. It has a proposal closing date of November 30th of 2022, and right now we're reviewing the responses. And lastly, we were asked to provide 2 reports on CFC and community option waiver financial and registry data, and we happily concur. We're happy to provide that to you. And with that, that wraps up our response, but we are happy to take any questions.
Wonderful. Any questions from the committee? All right, I have a couple brief ones. In terms of the disagreement over enrollment numbers or unenrollment numbers, if you will, in Medicaid, obviously we're talking about the folks that are aging out and then other categories. What do you see as your delta of folks who just simply are not going to come back for whatever reason outside of the specified categories, folks that may just fall off and we may not be able to find again? Is there a number that you're anticipating there?
We don't have an estimate on that. The federal government is really providing all incentives for states to make sure that they encourage and make every effort to get people back onto the Medicaid rolls. For example, they're requiring us to not require individuals to fill out a full application 90 days after they forgot to send back their information. So within 90 days, they don't have to fill out any new information, and we're required to put them back on the Medicaid program.
And then the other question I had, because I've been dealing with it for a couple of years, as you mentioned, under value-based purchasing. So when the second round was redistributed, there were 2 MCOs that got a windfall. Let's just call it a windfall. Right. That's obviously not happening anymore under the new program. Do you know what they did with that extra money? Because I'm concerned that if they had started up programs for their subscriber base that they are no longer able to continue, that might have a negative effect. Do you know where that money went with regard specifically in JAI and then Kaiser, especially JAI, who was a very small MCO?
So what I can say is we never asked those questions. What we did say, though, for calendar year 2021, those payments weren't guaranteed at that level, and that potentially they should use it for future operations.
Got it. All right. Well, thank you very much. One last chance. Any other questions? Being none. Thank you all very much. As I mentioned, we do have a number of people signed up to testify. We will be timing folks at 2 minutes. So we will just bring everybody up. And if you are here, please come up. If you're not, we'll skip you. So we'll start with our first panel, Margot Quinlan, Mary Backley, Joseph D'Amatos, and Dan Shattuck. Dan, I have Barbara signed up as well. I'm assuming it's just going to be one of you? Yeah. Okay. Please begin in that order if you'd like.
I'll jump in. Thank you, chairs. Thank you, chair and members of this committee. My name is Margot Quinlan with the Mental Health Association of Maryland. We're here in support of the budget. We really just wanted to lift up one key program that supports vulnerable older adults with mental health challenges entering nursing facilities. And so the program is the Pre-Admission Screening and Resident Review Program, or the PASSAR program. It's a federally mandated program that every state has to administer for Medicaid certified nursing facilities, and really just screening to make sure that folks entering those facilities are entering the right level of care, that services are appropriate, and that they're going to be, their needs are going to be met. And as our older adult population rises, as there's a dramatic increase in older adults with mental health challenges, and folks who are aging with mental health challenges, this is a really critical program to make sure that folks are placed in appropriate levels. Unfortunately, the federal regulations haven't been updated since the 70s, and so Maryland is really in a moment where we think we can lead. And there was a JCR that was authored over the interim this last summer in 22 that really talks to the need to increase funding for the PASSAR program. And so we really just want to lift up that JCR. Our testimony has a link to it and references it, and just ask for this committee to look at that program and consider additional funding to help modernize. The PASSAR specialists are doing all of this work on paper and pencil still, and can we help modernize the system and really increase the efficacy of getting older adults with mental health concerns into the appropriate levels of care? Thank you.
Thank you. Ms. Beckley.
Yes, thank you. Good afternoon. My name is Mary Backley. I'm the Chief Executive Officer of the Maryland Dental Action Coalition. I would like to take this opportunity to thank you all for passing Senate Bill 150 in last year's session, which is providing much-needed dental care for hundreds of thousands of adults in Maryland. The program started two months ago today, and as conveyed earlier, adults are utilizing the care, getting care that they much needed, and it's going to have a profound impact on their life. I would also like to take the opportunity to thank the Maryland Department of Health. Maryland Medicaid has been a great partner in this effort, and we really are very pleased with the funding that was provided and are deeply grateful for the funding in the budget. So I respectfully ask for a favorable report. Thank you.
Mr. Chair, members of the committee, I'm Joe D'Amatos. I'm the President and CEO of the Health Facilities Association of Maryland, testifying in support of the budget. The Health Facilities Association of Maryland is 76 years young. I have not been there all 76 years, and we represent skilled nursing and rehab centers and assisted living campuses throughout Maryland. You have our testimony. I'll just summarize a couple of very important points. First, Mr. Chairman and members of the committee, I want to thank you genuinely, deeply, and personally, because as the COVID pandemic advanced, it was actually this committee that looked out for us and provided the funding that we needed, and that should be said publicly and acknowledged. Sadly, in skilled nursing and rehab centers and throughout healthcare, we're still dealing with what is now endemic COVID-19 and all of the financial and medical factors that we were hit with during the pandemic. What that looks like in nursing homes is costs that are still through the roof, but revenue that's in the basement because census is historically low. We are experiencing all the same inflation that each of us are. Chief amongst these is wage inflation. So the 4% in the budget is really desperately needed. And to the extent that the General Assembly decides to accelerate the minimum wage, regardless of how far, how fast in the final effort, we really need desperately the funding that goes with that. Finally, I just want to commend the Health Secretary for hitting the ground running in the way that she has, Trisha Roddy for being such a great partner throughout these years, and to wish Webster well in his new job. Thank you, Mr. Chairman and members of the committee.
Thank you. Mr. Shattuck.
Thank you, Mr. Chair, members of the committee. My name is Dan Shattuck. I'm here today on behalf of a number of our healthcare and long-term care clients. I just wanted to make 2 points today in support of the budget. One, to thank the governor and the department for maintaining the physician evaluation and management codes at 100% of Medicare, even in the face of the 2% decrease at the national level. This is hugely important as our physician providers are grappling with really historically low reimbursement in the state of Maryland, and for Medicaid to make this commitment, it's very important, particularly for our neonatologists who provide care to a large percentage of moms and babies who are on the Medicaid program. So thank you for that continued funding. I also want to thank the governor and the department for providing an additional $15 million for the home and community-based options waiver. We really appreciate the efforts of the department to scale up staffing as they embark on increasing the number of slots to 7,500. And as they start to send out the 600 waiver applications later this summer, we're confident that the department's actions in those areas will help address the extensive waiting list that exists and will allow more people to receive care in the community. So again, we're here in support and we look forward to working with the department on these important issues.
Thank you. Any questions for this panel? Seeing none, thank you all very much. I'm going to move to the next panel. Brian Frazee, Dana Kaufman, Jocelyn Buchanan, and Mark Bain. Mr. Frazee?
Right. Good afternoon, Mr. Chairman, Madam Vice Chair, members of the committee. My name is Brian Frazee here on behalf of the Maryland Hospital Association. You all heard me testify on the same issue yesterday during the BRFA hearing, but I did want to appear before the subcommittee on the Medicaid budget to share our gratitude to Governor Moore for including a one-time $50 million reduction in the Medicaid deficit assessment in his proposed fiscal year 24 budget. We are asking that the General Assembly protect that in the BRFA and the Medicaid budget. There are really two reasons why that's important. Number one, it goes directly toward reducing patients' hospital bills in the state, and it also alleviates pressure on our total cost of care model at a critical time as we enter renegotiations with the federal government on that issue. So we appreciate the governor's support, and we hope that you all will support that reduction as well. Thank you.
Good afternoon. My name is Dana Kaufman. I'm here today on behalf of several organizations, Lifespan Network, Maryland Association of Adult Day Services, and the Maryland National Capital Home Care Association, and they do have issues that do trend across all three. One of those is, and it was noted in one of the documents supplied earlier this session by the Health Department, and that's the approval of care plans and the delays that are occurring. We will look forward to being able to work with the department to try to expedite those care plans, but they do have a significant impact on the ability to get individuals approved so that they can begin receiving services, and that's an issue that goes through all of the home and community-based services. We're experiencing issues in medical adult day, home care, as well as assisted livings in the community options waiver. The other issue, which is very similar, is just dealing with the nursing homes and the problem resolution unit, which deals with trying to, after somebody has been deemed eligible, it works to actually get payment. And it's an issue that is between the Department of Human Services as well as the Maryland Department of Health. We have, I think I have it in my my document, but we have a couple millions of dollars that are sitting there in waiting for resolution. So again, we need to make sure that that's a priority. And then the last issue I am just going to raise is last session you gave $20 million to the assisted livings to help with COVID relief. It was a long process to set that monies up for distribution. The distribution was done around November, December, and only $12 million was actually given out of the $20 million. And we did go back and ask for a second round to be given to the assisted livings in the of $8 million, and that has never happened, and we were told no. But I'm going to ask that since you gave $20 million, if you would authorize the other 8 to be given as well, since that was really the intent. So with that, we look forward to working with you. Thank you.
Chair Resnick and members of the committee, thank you for allowing me to share some concerns. I'm Dr. Mark Bain. I'm one of the co-owners of Comprehensive Nursing Services. We are a licensed RSA, Joint Commission accredited, and we've been servicing the Medicaid community for private duty nursing. We have a nursing crisis in this state, and we are being reimbursed at a dramatically less than our surrounding states in the District of Columbia. The reimbursement might explain why we have some 97,000 plus nurses that have active license in this state, but only 61,600 of them working here, meaning that 36% of our workforce is not working in the state of Maryland. Just to give you an idea of some rates, Maryland, we're at $46.33, Delaware $53.06, Virginia $63.43, and DC at $75 an hour. And RN rates are just the same way. We have 8 times as many RNs as LPNs in this state, but we in this state are reimbursed on technology rather than education, meaning that an RN only gets RN rates if that patient has a central line. All other states give reimbursement rates based on education and not patient acuity. Now, third point I'd like to make is that a legitimate W-2 employer, we see the same rates as a 1099 company. We correctly classify our employees. Our reimbursements are exceptionally unfair as we have much more of an overhead, such as workman's comp, Maryland unemployment, FICA, and we're obligated to pay, for instance, time and a half. We're not given time and a half from the state of Maryland, but we do pay it. And just to give you an idea, in 2022, we put out 6,365 hours, which cost the company some $95,000. We do it because it's the right thing to do, and we do care about our families and our patients. Thank you for letting me share.
Thank you. Any questions for this panel? All right, seeing none, thank you very much. We're going to move to, I should have called one more person. The last witness, Art Estopinen. How'd I do?
Very good. Very good.
All right, sounds good.
Thank you so much, Mr. Chairman.
Please begin.
So good afternoon, Chairman Resnick, Vice Chairman Shetty, and members of the committee. It is indeed a great honor and pleasure to have the opportunity to represent a grassroots organization known as FAME, Families Advocating for Medical Complex Patients at Home, Enacting Change. We started this group for families that rely on home health care nursing for themselves and their loved ones. We have recognized the need for reform in the state of Maryland to increase the availability of home care nurses. As a former retired federal employee for almost 3 decades in the United States Congress, I would like to thank each one of you in this distinguished committee for your services to help the residents in your role as a legislator and your commitment to help the disabled citizens. Many of our loved ones will be unable to live. For example, I have a son who suffers from a myocardial disease. It's a very rare disease. He was given 2 months to live, and last week we celebrated his 12th birthday. The nursing care at home has been critical for my wife and I, and many hundreds of Marylanders in this state. Our children will not be able to thrive without the pivotal assistance that the state of Maryland provides. We are so very grateful. However, due to the competing factors of care in other care industries in Maryland, nurses have started to leave our state for professional work in the surrounding states. The nursing shortage in the state of Maryland has been further exacerbated by COVID-19. Our families are going without much needed sleep. My son requires 24/7 care, and my wife and I do our best. I still work, she does not, but the nurses that come at home are really pivotal for us to be able to continue our day-to-day activities. Struggling day-to-day activities without the assistance of these nurses is very, very detrimental to our family life, and we are asking to please help us with a larger supply of nurses to meet the demand. As our group, we're working to enact reform to legislative and regulatory requirements that we feel, if enacted, would make an impact in the availability of home health care nurses in the state of Maryland. The changes include immediately increasing the MA home duty nursing reimbursement rates to commensurate with the reimbursement rates of the surrounding states that was previously mentioned, because Maryland reimbursement rates are lower than Delaware, Pennsylvania, District of Columbia, West Virginia, and Northern Virginia. Allow new grad nurses to work in home care. Currently, nurses must have 1 year of clinical experience to work in home care. Number 3, allow the existing RN reimbursement rate to utilize for all RNs working in home care, instead of allowing this rate to only be utilized for specific patients based on technology. And finally, remove the regulation that restricts home care nurses from working more than 60 hours per week. Those are some observations from all of our parents that we would like for your consideration. And once again, on behalf of FAME, I would like to thank you for your support and interest in assisting the members of the disabled community in our beautiful state of Maryland. Thank you very much.
Thank you. Any questions for this witness? Seeing none, thank you for coming to testify.
Thank you.
We appreciate it. I believe that was the last witness, so that we will see everybody tomorrow for the last budget hearing before we enter decisions next week. Appreciate everyone coming down to testify. We are adjourned.